Orthodontic Appliances by Andrea Marquez and Laura Lugo. The learning objectives are to recognize keywords and terminology used in orthodontic therapy, to explain the advantages and disadvantages of bonding brackets, to summarize the clinical procedures for bonding and debonding, and to develop oral self-care recommendations for the orthodontic patient to address effective biofilm removal and reduce risk for dental caries and periodontal disease. Cemented bands and bonded brackets. Resin bonded brackets have been used widely in orthodontic treatment. They are usually placed on the facial surfaces of the teeth, but they can also be placed on the lingual surfaces. They aid in the application and control of applied forces necessary to accomplish tooth movement and bone remodeling for orthodontic therapy. There are two types of brackets, single bracket and twin bracket. The advantages of bonded brackets are improvement of aesthetics, caries can be detected and treated faster, and there is less patient discomfort because there is no need for tooth separation as required for band placement. The disadvantages of bonding brackets are weaker attachment. Bracket may detach more readily than a band because attachment may be weaker with less surface area in contact with the tooth. Another disadvantage is time consuming when rebonding because it requires more tooth preparation. Cemented bands and bonded brackets continuation. Brackets can be made of metal, plastic, ceramic, or plastic with metal reinforcements. This is an example of a ceramic twin bracket, and this is an example of a metal twin bracket. Brackets can be made in many styles, shapes, and sizes for different teeth, each designed to accomplish a specific objective of treatment. Arch wire attaches to the bracket to generate and distribute forces that guide orthodontic tooth movement. They may be rounded, rectangular, or multi-stranded. This is an example of how they look. Elastomers are available in latex and non-latex materials, and they come in a variety of colors. They are used as chains and on individual teeth to hold wires in the brackets and to apply light continuous force to close spaces between teeth. And this is an example of elastomers. Cemented bands and bonded brackets continuation. Removable aligner system. These custom clear thermoplastic aligners are fabricated by taking upper and lower impressions of the patient's teeth. Retention attachments are bonded on the teeth so the aligner has a place to clip into place. A number of aligners are given to the patient to wear per instructions. The patient will visit the orthodontist on a regular basis to monitor progression, and impressions must be taken again for the fabrication of retainers to maintain orthodontic movement. Clinical procedures for debonding. Assessment examination. It's important to document all irregularities of the patient's teeth in order to prevent any misunderstandings after debonding. The procedures are: principles for pitting fissure sealants apply for bonding orthodontic brackets. Make sure to remove all calculus and remove excess material around the bracket. Characteristics of bonding relating to debonding. Nature of the bond. The acid edge exposes the prism structures of enamel and creates microclefts. On the bracket side, the resin becomes locked into the mesh base. Effects of filler particles. Fillers added to the resin increases bond strength, hardness, and wear resistance. Ease of debonding can be related to the type of resin and length of etching time. Heavily filled composites are thicker and may be more difficult to remove. Etching time of 30 seconds significantly improves bond strength for orthodontic brackets. The bond is stronger when a smaller layer of resin is placed between the tooth surface and the bracket. Anterior brackets may be bonded with a light fill resin, and posterior brackets may need a heavy fill resin to prevent the attachment. Use of fluoride releasing bonding system. Use of fluoride releasing bonding system can prevent demineralization around brackets. Dental hygiene care. The patient may be under orthodontic care with regular appointments for a long period, frequently years. Communication between the orthodontist and the patient's referring dentist and dental hygienist is required to coordinate oral self-care instruction along with other essential dental and dental hygiene care. Regular dental hygiene, preventive care, and motivation for oral self-care are essential during orthodontic treatment. The risk factors are age groups and systemic conditions. Many orthodontic patients are in the preteen and teenage years, periods when the incidence of gingivitis is high. The incidence of periodontal infection increases from early childhood to late teenage years. There is a significant increase in the number of adult patients seeking orthodontic treatment. As with younger patients, the risk factors for caries and periodontal disease increases. The adult orthodontic patient may be taking medications or have a systemic condition that can complicate therapy. Gingivitis. Dental biofilm retention around orthodontic appliances leads to gingivitis, just like in the picture. The degree can vary from slight to severe with gingival enlargement, particularly of the interdental papillae. The tissue may greatly enlarge and cover the fixed appliance. The enlarged tissue with pockets provides additional biofilm retentive areas. Position of teeth. Teeth that are irregularly positioned are more susceptible to retention of dental biofilm and are more difficult to clean. With the severe malocclusions presented by orthodontic patients at the outset, the factor becomes even more significant. Problems with appliances. Orthodontic appliances retain biofilm and debris. Accidents may cause a bracket to become detached. Self-care is difficult. Even the patient who tries to maintain a good oral hygiene has difficulty. The appliances are in the way and interfere with the application of the toothbrush and other devices used for dental biofilm control. Instructions need to be very specific and reviewed at each appointment. Dental hygiene care continuation. Disease control. General oral self-care instructions. Make sure to give the patient good oral hygiene instructions before the appliances are placed. Interdental aids. A floss threader is needed for biofilm removal from proximal tooth surfaces when the appliance prevents passage of floss from the occlusal aspect. Tufted dental floss used in the floss threader can remove the biofilm more efficiently than regular dental floss. A single tuft brush can be particularly beneficial around individual teeth that are hard to access with a regular toothbrush. This closing solution is useful to help the patient self-evaluate biofilm removal. A disadvantage is that disclosing stains may be difficult to remove from the bonding resin. Caries prevention is necessary, part of minimizing and preventing white spot lesions. Sugar-free mints or gums containing xylitol may be used between meals. Diet counseling is needed to ensure a patient understands the foods and beverages most likely to impact future dental caries. For patients with xerostomia, saliva substitutes and dry mouth products may help reduce caries risk. Recommend and approve mouth rinse to aid in dental caries control and periodontal inflammation control. Toothbrush selection. Power brush. Used with soft filaments, a light stroke, and at a low speed, powered brushes have been shown to be more effective for maintaining gingival health and cleaning around the appliances than manual toothbrushes. Manual brush. Soft brush. A soft brush with end-rounded filaments is recommended. Toothbrushing procedure. Circular brushing. A circular method is needed by most patients for cleaning the appliances and maintaining the gingiva. Power brushes are adapted for circular as well as any other brushing procedures. Adapt for appliance. Special adaptation is required for facial surfaces. Place the brush with filament ends directed toward the occlusal surface to clean under the wire and bracket for mandibular arch. Place in Stillman position for the opposite side. Clean all surfaces of biofilm and food debris. To ensure cleanliness, one needs to brush the appliances in any way that the filaments can be manipulated. Insert the brush from below, over, and above the arch wire. Rotate and vibrate to remove biofilm and debris. Lingual and palatal. Approach to brushing is similar to the basic strokes used on the facial surfaces. Additional measures. The entire self-care routine is kept as simple as possible. It is a challenge to find the most effective therapeutic aids for the individual needs of the patient. When suggesting a new aid, be sure to eliminate one that did not work well for the patient. Document changes to the oral care plan in the patient's chart. Oral irrigation. Most patients who wear orthodontic appliances can benefit from the regular use of water irrigation for removal of loose dental biofilm and food debris. Oral irrigation, particularly with an orthodontic tip before brushing, is recommended so debris is removed to provide access to enamel surfaces for the fluoride dentifrice. Dental hygiene instrumentation. It is difficult to instrument manually around orthodontic bands and brackets. The use of an ultrasonic or sonic scaler is helpful. The use of an air polisher may be indicated since the bands and brackets can tear polishing cups and the agent is less abrasive than polishing paste.